I am Eileen Sandberg, Training and Support Specialist with RTSC. Today's webinar is Emergency Services in the Commonwealth with Christopher Lauzon, the Director of Emergency Services at the Riverside Community Care South and West suburban area. Christopher has provided community-based social work and clinical services for approximately 20 years. He provided direct services both in clinical and in case management and has worked in outpatient, CBHI, and emergency services. Welcome, Christopher.
Thank you. So as was said, my background is in both CBHI services. I served as an intensive care coordinator for quite some time, and then I moved into emergency services as both a clinician and then on to a MCI manager, and now I'm a program director. So today our goal basically is to answer any of the questions that you have to help you understand more about emergency services, to expand your knowledge on the services that are out there for CBHI. I do not have all the answers, but if you have further questions, you can reach out to the Federation and I will get them the answers if I don't have them today. So we will start off with looking at our objectives. Mainly our objectives today are looking at CBHI services, how it was established, what are available services, and then breaking down these services to their types, what you're looking to get out of them, how they differ, and ultimately who would be eligible for the services, how a parent can get services for their child, the application process and time frame, and where services are available, and whether or not a private insurance covers these services, which as we get to that gets a little complicated, but we'll talk about that a little bit moving forward. As you move along, if you have questions, feel free to type them out. I'll try to answer them as if they're pertinent at that time, but we will have a Q&A at the end. So hopefully by the end I have a lot of your questions answered, but please don't hesitate to send them in because we're tracking them, and we'll get to them at the end, or if they're pertinent to the presentation at the time. So the history of CBHI services some time ago was what is known as the Rosie D lawsuit. So there was a group of individuals that came together and formed a class action lawsuit, and their goal was to have services available for individuals that needed them. And out of that lawsuit came what was a requirements of the state to provide services, which resulted in court monitoring. So those services, it continues to be monitored and are provided to any individual under the age of 21 that has qualifying special needs and or mental health challenges, and that has a Medicaid product or is considered uninsured at that point in time. So Children's Behavioral Health Initiative is what CBHI stands for. That initiative has been ongoing at least since I started working in the states in this state in 2009. So I don't know exactly the start date, but it's been going on for quite some time at this point. Why is it so different from other services? As I said before, we can get to this, but the services weren't always necessarily available to those that are privately insured. And so I'll expand upon this, but there are ways in which currently to expand upon your coverage so that you have a Medicaid product so that you're eligible for CBHI services. Because as of now, CBHI services are only available to individuals with a Medicaid product. So intensive care coordination. Intensive care coordination is meant to assist in having an individual that has needs, identifying those needs in the development of what is a vision. So looking at life as it should be with a family and with an identified child as the family and the child would want it to be. And so by creating a vision, essentially you're measuring where the family unit and the individual are at the time and where you want them to be, and you're finding the gaps. And so an intensive care coordinator is meant to assist the family in making the progress necessary in order to get to that vision. And by doing so, they create a team. So a team could be, personal supports, professional supports, but it's ultimately identified by the family. So it's family first, family voice and choice. They get to choose who's on that team. So we may get to this, but there might be times where there's challenges, say, with a school system. And so the family may decide that they, at that point, don't want to include the school system, but the school system would like to be involved. The intensive care coordinator helps to bridge the gap, despite the fact that the family may not be ready for the school system to sit in on that team, so as they still can have sufficient communication to move forward towards that vision. It helps, an ICC helps to ease the strain in what is sometimes challenges between a system and between a family unit or an identified individual. So intensive care coordinators, they look at what the goals are in order to get to that vision. They set those goals, and then they monitor and track how a family is moving towards the goals. Ultimately, an intensive care coordinator oversees the support that would come from what is next in line here, a family partner, or FS&T. And so the family partner is there in order to assist in the guardians, to assist other collaterals, and assisting the family unit in reaching whatever goals are necessary in order to attain their vision. So in a way, ICCs are seen at times as case managers, but that is not the entirety of the role. In fact, what they are more supports for the entirety of the team rather than a case manager. Their job is not to set the goals. It's the team, which is the family unit, the identified individual, and then whomever they would like to include on their team. It's to assist them in developing those. So quasi-case management, I guess. So they follow up and they assist in the communication and tracking those goals. So family partners, you find in multiple aspects of CBHI services. So we also have them, and I can get to this when we talk about emergency services, but you'll find them both in emergency services and in the world of ICC. They now, as of a few years back, now can be referred individually as long as they have what's called a hub. So we could circle back to that, but you need essentially goals for any of these services that are measurable and considered therapeutic. So you could have only a family partner if you had an outpatient therapist that was willing to be what's known as the hub, to provide therapeutic goals for that individual. So they would be providing supports to either to a guardian or to whether it's temporary or long-term, or a parent, permanent guardian, but they don't necessarily have to be operating underneath an intensive care coordinator, which coincidentally can also be a hub. So you could have a hub that is an ICC. You can have a hub that is an in-home therapist, I believe, and I could be corrected on that. You could have a hub that is an outpatient therapist. So as far as I know, those are your hubs. I think a psychiatrist could be, but I don't know of any psychiatrists that are. So at this point, so you'd have, now we've covered intensive care coordination, which is a wraparound team or an individual that manages or helps to manage the wraparound team that is seeking a vision. You have a family partner that may or may not be part of that tandem that sits on that team and works with intensive care coordination. You have family partner that might be standalone as long as they have a hub. Then you have potentially a family partner that works in conjunction with mobile crisis intervention, which is an emergency service program. So as we move down the line, we have in-home therapy. In-home therapy is meant to, so it's more of a long-term service. When you have an in-home therapist that comes in, they're generally working with a family unit, not necessarily, but They generally are looking at the entirety of the family unit. The difference between an in-home therapist and an outpatient therapist is exactly how it sounds. They're working more in the home atmosphere. They're developing and working on goals that have to do more with the unit, interactions in that specific home. It could be transitions back into the home from school. It could be transitions out of the home to some sort of family development. It could be discussing with the family unit how it is that the family interacts. But you're looking at there's goals that are there, but they're long term. They can shift with the needs of the individual. Then you have in-home behavioral therapy. So ABH services, which generally you're looking at a specific behavior. You're monitoring a specific behavior. It's sometimes a little bit harder to get, and it is generally a little bit more time limited. It's not to say that there couldn't be medical necessity that would allow it to extend if that was the case, depending upon the behavior that you're trying to treat. But that is yet another version of what would be considered a home-based therapy, that it's a little bit more specific as to what it is that you're going to be trying to target. Outpatient therapy, most people know about. It's you have one single solitary therapist. You do not need CBHI services in order to access outpatient therapy. It is hopefully a little bit longer term, and it's meant to provide a child a setting for which they feel as though they have an unbiased individual who they can trust, who doesn't necessarily, although it has to be spoken to the identified that if it's a safety concern, they'd go back to the parent, but doesn't necessarily have to pull the parent in for everything, because the goal is to try and develop what feels like a personal relationship, but it's professional, so that you can really trust the individual, so that you can speak to whatever challenges that you're having on a weekly, bi-weekly, monthly basis. But personally, professionally, I think if anyone receiving therapy was going to have it on a consistent basis, it should at least be monthly. But if you're at the point where you need CBHI services, it's likely that it at least needs to be biweekly. And depending upon the tolerance of the child for the therapy and the relationship that they develop, I wouldn't hesitate to have a kid have weekly therapy if you can get it paid for. These are the general, the top are all of what would be considered services that you receive through CBHI out in the community that are readily available and would be scheduled, per se. Mobile crisis intervention would be the last, and that's through emergency services. Excuse me. So every town in the Commonwealth has an emergency service program that covers their town. Each emergency service program is responsible for a catchment area. No catchment area overlaps. So that means your town and the abutting town to you may have different emergency service programs. The emergency service program, each one in their contract with the Commonwealth, is required to provide mobile crisis intervention. What mobile crisis intervention is beyond what emergency services would typically provide, which is an initial assessment and intervention based upon a crisis, which could mean a lot of different things. And then beyond that, follow-up services that extend the intervention, so that if an individual, when seen by emergency services, was not appropriate for a higher level of care, whereas it's a 24-hour overnight placement, then ES and the mobile crisis team could follow up with the family, could follow up with the individual, could follow up with collaterals to continue to support and try and reach some of these goals and ease whatever strain is present. The goal of mobile crisis intervention is to intervene so as to help whatever decompensation that has been seen that is preventing the child or the family, in some cases, in multiple life domains from moving forward and feeling healthy and happy, to help them to get to whatever that next step is. It's not long-term therapy, although when mobile crisis intervention is in place, when you're working with a family unit or an identified individual, it often is therapeutic and feels like therapy. So you would have generally in a mobile crisis intervention initially, you would see a clinician, and you would have, if available, a family partner. So for instance, we staff as much as we can, as many hours as we can, family partners, but there's many evaluations throughout the day, and our family partner could already be on an assessment or could be out on a visit with a guardian or family member trying to provide support. So we try as best we can to have two individuals present if appropriate. So that in a nutshell is what mobile crisis intervention is. I could speak a little bit more to our practice at our particular location and general practices with other emergency service programs and with other MCI providers if folks have questions. In fact, I'd like to probably expand upon ours if possible down the road, but we don't necessarily have to go there right at this point in time. So that's a general overview of CBHI services. There are nuances in there, whereas an IHT team sometimes comes with a two-person, they come out. I think ultimately, if they interest you, then as you get connected to these services, you're gonna learn more about as you develop the relationship with that provider. So, and they're really looking to tailor whatever it is that they're providing for supports to you, your family, to your child, to the identified. So it doesn't always look the same, but that's the general overview. So some of the questions in regard to the services, how do they differ? I think hopefully I just answered some of that. Is there an overlap between services? There can be an overlap between services, absolutely. You could have any number of these services that I had mentioned on the previous screen at the same time. And honestly, if we have an individual that would say have 5 out of the 7 that I had mentioned, there's a high likelihood that at some point in time they either have crossed the paths of an MCI team or they will in the future. So it's not unlikely for somebody to have an outpatient therapist, have an in-home therapist, have an intensive care coordinator. In fact, the intensive care coordinator assists them, especially when as overwhelming as that can be for a family, in keeping track of all of the services that they have and helping them to manage and sometimes muddle through having to keep all of these appointments. And the last thing anyone wants that provides these services is for a family to feel burnt out, because it prevents a child from opportunities that are out there. So absolutely there could be overlap. Because it's family voice and choice, if at any point in time it is overwhelming to the point where one service may not be necessarily needed, then the goal is that to have open communication so that you can decrease the services if necessary to the point where it's manageable and you don't feel like you're going to burn out. So yes, overlap. How many services can you have at one time? It's technically unlimited. I think at a certain point when you have a provider that's paying for the services, then you may have a case manager from a provider of insurance coverage that may look at what it is that you have exactly. I think those conversations are kind of ongoing, and so those are the providers of the service. So your in-home therapist, your intensive care coordinator, they're going to be discussing and they're going to be providing medical necessity for why it is you'll maintain those services. So it's less your responsibility to understand how many services you can have. It would be more your responsibility to speak to your needs and allow those that provide the service to have the discussions about how many you can have at one time. Unless you're overwhelmed, then I wouldn't worry about how many you can have at one time. It's more about meeting your needs. How do I know what services my child needs? Well, it starts by thinking a little bit about where it is you would like to see your child and where you would like to see your family. I think ultimately the folks that do this work understand how to address the needs of a family and an identified individual. And so if you feel as though you would have a vision, whether or not you were developing a vision without an intensive care coordinator, just think a little bit about where you would like to see your family, see your child down the road. And if you're not there and you don't necessarily know how to get there, then seek the help. That's the point of this webinar, is to understand a little bit more about where it is that you can go in order to do so. So you don't necessarily need to know all the services. You just need to know a little bit about it, and then trust in the direction that will be provided to you by those that provide these services. How do I know if my child is eligible for the services? So in order to be eligible for CBHI services, from top to bottom, except for the outpatient and the MCI, then you would need a Medicaid product, or your child would be uninsured. So that's any Mass Health product. If for whatever reason something happened and your child doesn't have insurance, then you would come forward and I would approach any of the providers and ask whether or not you would be. There are some nuances to it, and understanding insurances within the Commonwealth can be challenging sometimes. It can be challenging to providers too. And so the only way that we understand whether or not there's eligibility or how to get eligibility is to ask the questions. Don't let that hold you back. So in general, if your child has a Mass Health product, they are eligible. Whether or not you have a primary insurance, which is a private insurance, so say a Blue Cross, or you have a secondary insurance on top of the private that has Medicaid, if there's any Mass Health involvement, then I would go ask the question. If you have a need, go for it and ask. How do you apply for services for your child? I like to think at this point that a gateway for services for your child is MCI. So going through an ES program, we make referrals, and we know all of what are considered CSAs, so community service agencies within your area. So contact your local emergency service program. If it's not necessary that you would have an assessment, we can at least point you in the right direction to give you a few numbers to call. So I would start there. You could go to, there's, I think, NAMI's website. The Federation is going to be able to assist you with pointing you in the right direction. There's a lot of ways to get through it. And after we're done with this webinar, we're going to take some notes about what it is that we need to provide you as a follow-up for some links. But I would go start with the Federation, start with NAMI, start with your local emergency service program and the provider of mobile crisis intervention. What happens if my child goes into a crisis at the mall? Well, what does the crisis look like? Crisis means a lot to a lot of folks. If we get questions all the time as to whether or not at our emergency service program we should have a parent present with a child if a child hasn't mentioned suicidality or harming themselves or harming someone else. We don't look at crisis as only that which could present immediate harm. And what we would rather do is talk with a child and talk with a family to see whether or not we're looking at what is considered a linear decompensation, which could get a child to that point. So is the crisis at the mall just a tantrum, or did your child run off and elope at that point in time? Did they physically harm somebody else there or themselves? I look at all of that as a potential for an intervention. If it's at the mall and you feel as though you're in a stable place and you wanted us to come out and see your child at the mall, we would. And not every emergency service program would, and they all operate differently. I can only speak to how it is that we operate. So we're working to be as community first and see individuals in the least restrictive environment as much as possible. Meaning, and I think we're going to get to this further down, does my child having a crisis in the mall mean that in order for you to see me, that I have to have that child now go back to my home or go to your office or go to the hospital. If your child's stable in the center of the mall and that's where you want us to see your child, we're going to see your child there. I don't know if that would be the best setting because you have a lot of distractions around you, but we absolutely could see your child wherever it is that you need to be seen. And we'll provide the areas for which we cover with the follow-up after this webinar. But what I would do is, with these specific questions, especially if you know how it is that your child decompensates, how they react to certain transitions, I would reach out to whomever it is that is your local emergency service provider, ask for who's responsible for their mobile crisis intervention, and have a conversation about what exactly their protocols are and what it is they would come out to, what they expect from you in order to receive the services. But that is a development of the safety plan. It doesn't necessarily all have to happen at once. Don't feel as though you need to overwhelm yourself to come up with that level of plan. Allow, like I said, those providers that are around you, trust in them to create that safety plan. So it may be that your child in the mall tantrums when they don't get what it is that they need. That may mean that after the fact, in our case, once the child settles in the mall, maybe you come into the office or we come out to the home to discuss what happens at the mall with that transition, to see whether or not there's referrals that can be made, to put any supports in place to help with that interaction that typically happens so that you decrease those interactions, so that the child's happier when they go to the mall, so that you have an easier time moving through the mall. So it doesn't necessarily have to be at that crisis point in order for emergency services to be involved or mobile crisis to be involved. How long does it take for a mobile crisis clinician to come to my home when my child is in crisis? So there's a lot of factors that go into emergency services and to mobile crisis. We could have 6 clinicians on at a time and 2 family partners, and at any point in time, because it's rather unpredictable, they could all be out in the community. So we try to be as transparent as we can on the front end. We're gauging what level of crisis there is at this point in time, whether or not there's an immediate intervention that is required. And so if at that point in time, either yourself or someone else in your family or your child is at immediate risk for harm to themselves or others, we're still going to try to come out and duly respond with our first responders, our counterparts in the police departments and the fire departments, so as to avoid having to go directly to a hospital. There may be times, though, that either it wouldn't be safe even for the clinician to be present, and so there's an immediate need in order to have a child in what would be considered a safe place, which is oftentimes an emergency room. So we could go that direction, but we try our best not to. There may be times where we might be reviewing a crisis or what was considered a crisis, whether it be at school or earlier in the day. Now a child is settled. Maybe it's not even a good time for us to be going out or for you to come in to see us. And so you're not quite ready at that point in time. And so we would get creative and talk about a time where we could send somebody out to see you or you could come see us. We're looking least restrictive, which in a lot of cases means when is it best for you and your family? So sometimes it's best for us to be immediate. Sometimes we can go when it is best to be immediate, and sometimes we can't. And so we talk through that and try to be as open and transparent as we can in regard to that. There's also times where it's best for us to plan, and so we are planful and are transparent about that, so that we can meet your child and your family where it is that they're at.
We have a question.
Sure.
If a family has Mass Health Family Assistance, this program does not cover all CBHI services. What Mass Health product should the parent request? Would they be eligible for a different program, or should they consider child disability supplemental insurance if appropriate?
I think if appropriate, you need to circle back. We have a list of what covers what services in regard to emergency services. First and foremost, if you're starting there, we're going to have a better idea of what you're going to be eligible after the fact. In the case of our program in particular, we are 100% insurance blind. So regardless of what insurance you have or lack thereof, we will see your child. I know that there are some cases whereas depending upon what insurance an individual has, there's a requirement to go through what would be a hospital-based team. In our case, I can only speak to what it is that we do. If you fall in one of our catchment areas, then we'll see you no matter what. But yes, there is some challenges with family assistance. There's challenges with having a health safety net plan. There are other plans that are out there. For the most part, if you want the full range of services, then you're looking at a Network Health or a Beacon product or MBHP. So we can speak more to those, and I could probably drum up a chart that we can pass out to the folks after this and have listed. Any more questions?
No.
Okay. How do I get mobile crisis to come to my home in the middle of the night? Again, in our case, it's about safety. So we're looking at the safety of the home. We're looking at the safety of the individual that's identified. We're looking at the safety of our clinicians. So if it all works out, if we need to, we're duly responding as if it's a wellness check. So we have an officer because we don't put hands on. And so we're trying to figure out whether or not we can manage on the front end. But our team is being told we just go, but we still have to ask some basic questions. So for instance, there's been a safety plan in the past, whereas the more that the parent talked about on the phone, the more agitated the child became. And so we know that in that safety plan that there are certain yes/no questions, and the parent knows that we need to ask in order to know whether or not it's safe for us to go out. But aside from that, we're trying not to further agitate the child, so we're more just going to go. But every situation's different. I mean, we plan as best as we can, but you can't predict how every crisis is going to look and what the response needs to be for every crisis. So you call the number and you ask, and you're honest about what's going on to the best as you can. If a child can be safe and there's another parent around, or there's an older sibling that can help be with the child, and you can take some distance to be able to fill us in as much as you can, that's better. But there are some instances that you can't. Are there times that mobile crisis clinicians stop taking intakes? No. Nope. We're 24/7, 365. There are some MCI programs like ours, for instance. We don't necessarily always have a family partner per se that's available all night long, every day of the week. But we'd have clinicians 24 hours a day, 7 days a week, 365 days a year. So we see anyone that requires an evaluation, and an evaluation doesn't necessarily mean it's an evaluation. It could also mean that it's an intervention just as much as an assessment or an evaluation. So if you feel as though you need it or somebody needs it, then you call. And then we talk through it and we figure out how it is that we're going to provide as much support as we can in that particular instance. Why is there a discrepancy between information provided by clinicians regarding insurance and bed availability? So I'll try to approach this one as best I can because I'm not so certain that there's a discrepancy as much as there is oftentimes not a full understanding of what's available based upon a person's insurance. So insurances and what they cover change. If you have a private insurance, especially one that's a national provider that isn't licensed within the Commonwealth through the Commonwealth's Department of Insurance, it's not necessarily as regulated. And so, you know, as far as what it is that we provide within the Commonwealth. And so we may not always have the answers as a clinician. So they're trying to be as straightforward as they can. They also don't have direct access to a central intake for the entirety of the state for what's available for beds because it doesn't exist. So finding a bed quite literally means at this point in time, if we are looking to place an individual, calling every single facility, as we do it 3 times a day, to try and figure out who has beds. And if they have a bed, presenting the clinical documentation so as they get reviewed, and then figuring out whether or not they'd be accepted. So we're giving as much information as we can and being as transparent as we can, but it's always a moving target. So I guess if there's any discrepancy, it's because it's a moving target, and it's because we don't necessarily always understand what the coverage will cover. What is the time frame for mobile crisis, and how is a case closed or transferred? So if we saw Johnny and Johnny had a crisis and came in and it wasn't appropriate to place in a higher level of care, so we didn't send the child to a CBAT or an ICBAT or an inpatient, which we probably should circle back if we don't to talk about levels of care. So they're not going to a 24-hour level of care and they're eligible for MCI services, then we could stay open for 7 days. If there is clinical justification for us to stay open longer, then we will seek that. And there are times where 7 days isn't the end. There's also times where a family says, at this point, we feel like things are settled. We're heading into a weekend. We have family coming over. Johnny's doing well. We have appointments on Monday with the in-home therapist, and we have a meeting with our intensive care coordinator next week. We don't need you to check in with us every day, where we would stop short of 7 days. It really comes down to what it is that the family needs at that time. Mm-hmm. So as far as transferred goes, we do transfer cases. The only time that we would transfer a case is if an individual resided outside of our catchment area and we saw them in our catchment area. So if, say, a child was going to school at a specialized program in Norwood and they lived in Quincy, then we would see them if they had there was some sort of crisis. We saw them in Norwood, even if whether or not we placed them in a higher level of care or we were going to do follow-up, we would generally follow for 24 hours. So meaning if they were going to a higher level of care, we would continue the bed search for 24 hours, and then we would transfer them out to their home emergency service program. Then if we were going to follow up with them because they weren't going to a higher level of care, then we would check in with them and we'd try to make it as much of a warm handoff as we could. So it's calling the family, letting them know who their contact's going to be, because we've now made contact with the emergency service program in their area. We've handed off the clinical documentation that we've had. We let them know what our goals were, and then the emergency service program in that area and the family would make contact in order to move forward.
May I ask a question about placement?
Mm-hmm.
If there isn't availability for placement specific to the individual insurance, doesn't the insurance need to offer services outside of the catchment area?
One more time.
If there isn't availability for placement specific to the individual's insurance, doesn't the insurance need to offer services outside of the catchment area?
There are cases where needs a tough one, because it's tough to tell an insurance provider that they need to provide services. We can provide links after this to health law advocates that could help you to move through some of these challenging situations, whereas you can't get the services that you feel as though you need, and there isn't parity between, say, someone with a similar presentation and another insurance. But in the immediate, if we're looking for a service at that point in time, we're often limited by what is covered. There are certainly cases whereas if an individual, for instance, had a private insurance and there were limitations on the availability of that particular service, that the insurance company would consider looking at expanding what it is, who they contract with, to have a single case agreement so as we could seek other placement. It does happen. It takes more work, and if I'm going to be 100% honest with you, it oftentimes takes more time. So if you have a child that's sitting and waiting in an emergency room and there's no bed availability based upon the insurance that they have, they sit there and wait, and it takes a few days of not getting any placement to be able to draw the weight and attention behind what it is that's being done for the work to get an insurance provider, especially a national provider, to consider paying for an out-of-network placement.
There's a follow-up. My experience with insurance has been inpatient placement is covered but not ICBAT or CBAT. Why is this, especially if inpatient is not appropriate, but ICBAT or CBAT is? Does the insurance follow the YMC recommendations if recommending CBAT versus inpatient?
The insurance does, but again, it depends on what it is you have for an insurance provider. ICBAT and CBAT in a lot of cases is paid for primarily by any insurance provider that would cover CBHI services. Mm-hmm. So if by chance you had say an out-of-state insurance, they're oftentimes either the provider of the service of that level of care, because they don't contract and therefore it wouldn't be sustainable, doesn't accept what would be a single case agreement. It's tougher to get, and so that limits you really only to inpatients. As far as in-state, if you're only getting an inpatient recommendation, if you have either if you have any of the Medicaid products and you would be eligible for CBHI services, then I would ask to go back and review with the director to see what the holdup is for the reason not being eligible for what would be considered a less restrictive level of care in an ICBAT or a CBAT. Generally, I don't in those cases see that being a struggle, whereas you would attain a lower level of care.
May I ask one more? May we briefly touch on the commercial insurers paying for CBHI in the future? What the question is I heard that in the future CBHI services are intended to be available to those with commercial insurance. Will this alleviate having children go to the Spruce Street location versus Lipton Center for Assessment? I'm sorry, I don't know the name of those.
Okay. I'm trying to think. Spruce Street versus Lipton Center. I think that's in my past somewhere. But so, but I can just touch upon CBHI services a bit. The reality is not everybody knows what the timeline is going to be for those that are privately insured. It's supposed to be that some services are on board July, and the reality is that rates are still being negotiated, is my best understanding, for how or what each insurance will pay. There's also a difference between whether or not a person is fully insured versus self-insured, which tends to be complicated. And I think, as discussed with the Federation, there'll be further webinar probably about moving forward about how it is an individual can navigate the system, because the reality is that the providers at this point in time are confused. There needs to be further discussion that happens, but the goal is really to open up these services at a wider array of services to a wider array of individuals, so that families aren't in a position whereas they have to go pay for a secondary premium in order to obtain the services. If I was to speculate at all, I would say that there may be some challenges in obtaining exactly what it is that you got eligible for CBHI. So there may be, with some insurances, in-home therapy now available that wasn't available. There may be, there might be MCI services and paid for that follow-up, that beyond, that you wouldn't get if you have a private insurance. So there might be some expansion, but I don't necessarily know at this point in time whether or not you're going to get exactly the same thing with the insurance that you have that is your primary private insurance. And at that time, I think there's been some discussion about whether or not you're going to want to switch providers. If you want to stay ahead of the game, I would stay ahead by talking to whoever your private insurance is and asking them whether or not you're fully or self-insured. As we move forward, that's going to become really important. There are some documents that are available that have been released by the Commonwealth and the DOI, so Department of Insurance or Division of Insurance, and you can read into those, but just track it. But to stay ahead, ask your insurance provider, call customer service, ask them whether or not you're fully or self-insured. That will be helpful in the future.
Okay. The comment here says Spruce Street is for adult assessments, Lipton Center is for youth. But if you have commercial insurance, the child still needs to go to the adult assessment location. Unsure as to why this is.
Okay, so this is that's a former lifetime. So when I worked with Community Health Link, that's where I started my career. So coincidentally, I know the difference between the two. It's because they have an identified team for mobile crisis. Community Health Link does. We operate with generalists, so we don't have a dedicated MCI team and a dedicated adult team. So it's just another model is really what it breaks down to. There are other emergency service programs that do that. In our case, we just operate with one singular team that will see any individual.
Okay. Let's go ahead then.
Why must my child be cleared medically by an emergency room doctor before a bed can be searched for them? Not necessarily true. So depending upon your insurance coverage, medical clearance can be attained sometimes in an urgent care or with a primary care physician. We do as much as we can have children or adults, if possible, board at home. There are some insurance companies, depending upon whether you got a private insurance or you have a local insurance, who would be more reasonable about recognizing that a level of care is necessary if a person was in the community. And in those instances, if you have an insurance that's more reasonable, we likely can be more creative of how we would obtain medical clearance. On the flip side of that, you have providers of services, so facilities that would only take an individual in based upon a certain level of care if they're coming directly from an emergency room. So we don't necessarily know those on the front end, and so that's why, like I said, sometimes it seems like an individual is being gamey, but the reality is that they don't necessarily have the full understanding sitting there with your family and your child trying to come up with what the next steps are to fully understand the facility that we might be sending someone to, the insurance and what their requirements are. And so you move through that. But there are certainly some cases where you don't have to go to an emergency room. I would say there are emergency service programs within the Commonwealth, though, that do operate more so in, depending upon their geographic location, in a medical facility, so see people more so in an emergency room. And so that feels like you need medical clearance. It's a little bit different than maybe we operate. So it's not to say one's bad, one's good, but in our particular instance, if we go out and we see somebody in the community or they come to our office, then ultimately we're trying to be as least restrictive as we can. And so that may mean that we see them, they're appropriate, say, for a CBAT, and it's most appropriate for an individual to board at home under the care of their parents. We feel as though their parents have a strong enough safety plan at that point in time for a few days to keep them safe. And so as we check in, we continue to assess that. There are certainly cases where it gets to a point where that no longer is safe, and now we have to use the emergency room. We have CBATs that, without having to go to an emergency room, will accept a child based upon a check-in with a primary care physician, if they had a recent interaction with a PCP, or if they're going to go see their PCP prior to admitting. But you really take it case by case.
Okay.
Are there any parts of the state that isn't covered by mobile crisis? No. Every part of the state is covered by an emergency service program, and they all have contracts for MCI. Is there any time that mobile crisis won't come to do an intake for my child? I wouldn't necessarily, first of all, call it an intake, because we're going out to provide an intervention and an assessment. So it's not an intake because it's a long-term caseload, because mobile crisis intervention, although it can be 7 days or sometimes we extend it if necessary, is still a time-limited service. So I would stay away from intake, first of all. But are there any times when they won't come do an intake? So those that have a dedicated MCI team sometimes will have their dedicated team stop at a certain hour, but then their emergency service program continues. I think each individual program has their own practices, and in our program, we'll go out 24 hours a day. We don't have a dedicated team, so you're going to get a clinician, and the clinician is going to come out and they're going to assess the situation like they would for a child, for an adult, for any presentation. The times that they wouldn't come out that you wouldn't get a clinician that's going to come out is when over the phone, gathering information, they feel as though it's unsafe to the point, whereas even if we were going to respond dually with a police officer kind of in tandem behind us to make sure that everything's okay, that we're that uncomfortable that we wouldn't even try that we would just call the police department. So other than that, other than there being an overt safety concern for those that are coming to provide practice or service, then we'll come out. Does a private insurance cover these services? Some, and like we discussed, I think there's going to be changes to it, and I fully believe that they're going to be beneficial to those that live in the Commonwealth. Unfortunately, I think we're going to have some hiccups along the way, and so we all just need to have a continued conversation about it. There are some services that are covered. There's some services that aren't at this point in time, but just ask your local provider.
And we also want to let you know that you can contact Pat Nemia at the Federation to answer questions about the private insurance coverage starting in July.
Awesome. What is one thing that you would like to leave parents and educators knowing about mobile crisis? So we're oftentimes seen as, or at least in the past have been seen as, a last resort. If anything, I would encourage all those that are seeking supports for an identified individual or family to think of mobile crisis as an intervention that absolutely does not have to be the last resort. The reality is that more often than not, when we're looked at as the last resort, we're very, very limited on what it is that we can provide. We do not want to put kids in 24-hour placements if we don't have to. We don't want children and families having to sit in an emergency room waiting for a placement. We want to meet families where they're at in the least restrictive environment. If that's at a school, if it's at a Dunkin' Donuts, if it's at our office, it doesn't matter where it is. We're going to do the best we can to meet you where you're at. And I think that ultimately, as long as we have open communication with each other, we're patient about what at times can be a challenging system, then we work through it and we figure out what we have for supports in order to help each other out. So that'd be it. Don't wait until you feel like you have no other option. Come to us as soon as you can. And then any more questions? We're getting close to wrap up, but I'll answer whatever I can.
I'm not seeing more questions. We'll give that a minute while I say thank you, Chris. That was extremely informative. I'd like to remind everyone that you will receive a follow-up survey, which we ask you to complete. We value this information so that we can provide everyone with the most effective information to support the wonderful work that you do in supporting children. Thank you again, everyone, for joining us, and we hope to see you again next month. This is RTSC.